Okay, thank you everybody for joining us online, and to those who will be viewing this, welcome. We are here today to get started on our webinar mini series, and we are going to be discussing aging in place. So I am going to start. My name is Sarah Utronki. I'm a Director of Patient Services with Ontario Health at Home, and I will be starting off our meeting with a land acknowledgement. So together we honor the land that we are on, even though this meeting is taking place virtually. If you're in the Champlain region, we are on the traditional and unceded territory of the Algonquin Nation. Algonquin territory spans almost the entire Champlain region. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and the Métis. These treaties and other agreements, including the One Dish with One Spoon, Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, European settlers, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. We are mindful of broken covenants, and we strive to make this right with the land and with each other. We are all treaty people. Many of us have come here as settlers, immigrants, or newcomers in this generation and generations past. Good afternoon and welcome, everyone. We're so pleased to have you with us today as we come together to reflect on and build upon the insights from our recent Aging in Place Forum. Whether you joined us for the full day or are reconnecting with us now, we hope you left that experience both feeling inspired and thoughtfully challenged. In the lead up to the forum, we hosted a series of pre-conference webinars designed to spark conversation and reflection about aging in place, focused on two deeply interconnected themes: supporting the patient and family caregiver, and understanding older adult demographics and health needs. These sessions laid the groundwork for what became a powerful day of collaboration on May 15th. On that day, we welcomed a dynamic group of participants, which included health sector partners, members from our Patient Family Advisory Committee, local and regional healthcare experts, municipal leaders, and engaged community members. Together, we explored, envisioned, and began shaping a shared future for aging in place in our communities. Today marks the next step in that journey. We'll begin with an overview of the forum report, followed by reflections from our PFAC members who will share their lived experience and perspectives. We'll then open the floor to our Ontario Health team members for questions and discussion around the recommendations. Our hope is that by the end of this session, you'll leave with a clear understanding of the vision we're working toward and the actionable steps we must take to bring it to life. And now it's my pleasure to hand things over to Jane OVOHT, our OVOHT lead, for her next updates.
Thanks, Sarah. So I'll be providing an overview of the report recommendations on behalf of Carol Green, who had something unexpected come up and couldn't make it today. So as Sarah had mentioned, we were really looking to have this Aging in Place forum across sectoral, bring a variety of different audiences together with the idea that we would create or co-create a 10-year vision with operational goals for aging in place across Ottawa Valley OHT. So really with those objectives in mind, we wanted to have a shared long-term vision, identify those priorities, and really look to see how we could facilitate greater collaboration and alignment across sectors. We knew there was a lot of great work that was happening, being discussed, being planned, and we really wanted to make sure that we had that opportunity to have all of those great ideas to come together and start to build that common vision. So with that in mind, we designed that day to really ensure that we were walking away with that a common understanding and that shared vision for 2035. And so in that, pleased to to say that we came up with every older adult in the OHT can live with dignity, stay connected to their community, and make their own choices, supported by local, equitable, and integrated care that enables aging in place within their choice. So really what we were hoping to do was have participants have open conversations, learn things, and they really identified areas and patterns that we have to shift in order to achieve this vision. And that really was around redesigning care and how we approach patient and community members' needs, making aging in place a preferred model over institutional care. And aging in place doesn't mean that we are not supporting long-term care, retirement homes, congregate settings, but it's people have the opportunity and the choice to make those choices. And then looking at how do we start to engage our community and our community members deeper in our strategic vision. So the strategic goals, we have 5 of them, and we'll spend some more time going into each of those. But within those strategic goals, we've also developed steps to get there. And admittedly, those steps aren't fully flushed out. They are recommended sort of first ways to get to where we want to go. And we hope to have conversations like this one today to really look at how do we make these the aspirational goals and the steps to get there into concrete actions that we'll be able to achieve by 2035. So for our strategic goals, the first one was really around community-driven co-design, and that has to be the core of any system change, that we need to ensure that it's for the community, by the community, and of the community. And this is to establish governance and accountability that really will ensure that we can, that what we do reflects what the community wants and needs. So our concrete commitment is by 2028, and it felt like a long time in May, but feels less now, that we will have health neighborhoods that are established with community tables with co-design authority for local service design and evaluation. So really, how do we start to self-organize at a community level to plan and execute in our healthcare and our social services? And within that, and I think this is something that our PFAC members will speak to, or at least certainly is near to their heart, is that at least 30% of those table members are citizens, caregivers, and people with lived experiences. So that this isn't a service-driven, service-developed plan, but it really is co-designed and shared governance with our community. So how do we think we need to get there? Through starting to develop aging in place community tables and leveraging what's already in place to see what we can do. And then really look at how do we promote and train older adults and caregivers around system and service navigation, self-management, health promotion, and health literacy. And so how can we move that forward even deeper than it's already taking place now? Our second goal was integrated coordinated access across the full range of care. So a single coordinated system for older adults and caregivers for health, social services, and housing. And by 2035, this would mean that older adults are able to access home care, housing, mental health, social supports, and primary care services through a single digital and phone-based entry point supported by a navigation team. It's lofty, but I think that's what we heard on that day was there's a lot of things spread out. So how do we start to coordinate more, better, and really across the different areas of a person's life so that we aren't necessarily siloing our sectors, but really addressing what the person's needs are. And so the recommendations that the groups came up with and the steps to get there was to really look at co-location and looking at how do we have deeper integration in our current partnerships and really working towards community hub models. So you're starting to see that theme around the community-based care. Really deepening our commitment to warm transfer across providers and cross-sectoral e-referrals so that we're able to track monitor, measure, talk about wait times, and have accountability. And then also ensure that we have self-referral options. So we're getting there, but I think even we need even further commitment around that warm transfer, and how do we make sure that people are getting to where they need to go. And expand those supports for families and caregivers through respite, caregiver support, training, and social supports, as well as advocacy for families and caregivers around employment and economic supports. And the last area, really to get to this piece, was around the partnerships across those sectors: seniors housing, income supports, primary care, that really looking at how could we get to that single point of entry, access, and then that navigation team. What do we need to do now? Because this is a much longer vision that we would like to work towards. Our third area is expand that infrastructure for older adults so that they can age in place of their choice. So what's the availability of supportive housing and home-based care technologies to ensure that people can remain in their homes or in their communities as they choose? So we set a goal here of by 2035, 75% of residents age 65 plus will be supported to age where they choose, whether it's in their home or with their family or in community. This would include access to tech-enabled home care, retrofits, and co-housing pilots. And there's lots of activity and lots of innovation that's happening right now. And it kind of like it blows my mind a little bit to think of where we'll even be in 5 years on how tech can assist people, how they monitor, and really ensure that people are aging where they would like to. And feeling safe and supported. And so really our job is to look at how can we enable this and make this happen. So some of the ideas that were put forward in the spring is to pilot a nursing home without walls model, which really is looking at taking that long-term care aspect and how do we move that outside of the walls of long-term care and into the community and into people's homes. That would include things like remote care monitoring, rehabilitation, and social engagement, because we know social isolation is a major impact on the overall health and well-being of people. We want to look at creating housing that includes different models and different ways that we can retrofit and enable technology into the home, both in rural and remote communities, to allow this to happen. And I suspect that we will continue to see advancements around this in the next few years. Invest in remote care monitoring, fall detection, and digital care support. So very similar to the previous, that we're ensuring that we are moving forward with tech-enabled home supports, and then ensuring that people are also comfortable within that. So how do we support the people in their home and the technology that is provided to make sure that people are feeling comfortable with that? And then centralized home and housing support team for seniors and caregivers that's really looking at rapid response, supportive access, and ongoing holistic care and coordination. And so, as you can see already, this is we were dreaming big and really allowing ourselves as a group during that forum to start to push that boundary and set our sights high into what we want our communities to be going forward, and how we all want to age in place in the next 10 years. So the fourth is to really strengthen our health human resources and reduce the turnover rate of home and community care by half and by 2035. So we know that sustainable team-based care delivery models, how do we leverage the scopes of practice? How do we ensure that we're bringing and enticing people to these positions and supports, volunteers as well? How do we start to work at this recruitment, retention, and continued education for a very healthy workforce in rural and remote communities? So again, that goal was by 2035, we're reducing the turnover of our staff through focused investments. We're looking at innovations and different models of care that make people want to come to work and feel fulfilled, and that we're assuring that our workforce is healthy and well looked after. So How do we get there? This one's a very long list, it seems, so the font's a little bit smaller. So looking at geographically based interprofessional primary care teams that are expanded to include PSWs, so personal support workers, paramedics, nursing, mental health, and volunteers. So really looking at what does primary care mean and how can we as a team start to look at this at, again, that local geography-based levels. Grow your own healthcare professionals. So we have some great things in the Ottawa Valley, and we're very proud of the communities and the land and the recreational opportunities that we have. So how do we capitalize on that and really entice healthcare professionals to remain in our communities and grow and learn in here while they're being able to pursue their professional ideas. Looking again at wellness and retention for across the sectors that are targeted, but particularly targeted for home care and community support workers. We know if we want to go to this vision of aging in place, that our PSWs and our community health workers are critical in order to make this happen. So those in the home care and community support services and paramedics services are really, really one of the linchpins in terms of ensuring that we have a healthy workforce to move forward. And within that, we also know that volunteers and caregivers really carry a huge bulk of the care that's taking place across for our seniors and in our families. And so really making sure that they feel supported through training strategies and opportunities to learn and feel supported. And then as a community, we want to ensure that we have welcoming communities that provide services, recreation. So we're enticing people to come and then working with our municipalities and better business bureaus and tourism departments to really create those communities that are welcoming and enticing. And then the last is really looking at expanding our training and learning pipelines across healthcare professionals. So really build on what's taking place in primary care, look at student engagement programs that would also include nursing, allied health, and personal support workers. Not to say that physicians and nurse practitioners aren't important, but really looking at what we've learned from there and build. And our last area for this report that I'm hoping reflects what the day was, and you're seeing that there's some familiarity here, is that we embed equity into the aging in place systems and care, so that we're really ensuring that we're using an equity lens and in eliminating systemic barriers. And so we set up a goal by 2029 that equity-focused programs and services for Indigenous, Francophone, 2S LGBTQ plus and other seniors and older adults in rural communities will increase by 30%. So really looking at how do we target our programs to those equity deserving groups. And this would include, we set a concrete target of at least 2 new cultural safe care initiatives co-designed with community partners to ensure that every OHT organization has completed foundational training in cultural safety and trauma-informed care. And so how do we get there? We start to prioritize our own investments in equity deserving groups, and including Indigenous peoples, 2S LGBTQ, and lower income seniors. We collaborate with the Indigenous Health Circle to support culturally appropriate and safe care and services for Indigenous seniors, caregivers, and their families, and then start to offer or expand culturally safe and trauma-informed training for all of our OHT members. So that is the results of the day-long conversations that we had. We can certainly talk about those goals, but first what I'd like to do is hand it over to 2 of our patient, family, and caregiver representatives that were also able to attend the day with their reflections and some thought-provoking questions. So I'll hand it over to Moira and Bonnie for further conversation.
Thank you, Jema. So Bonnie and I've had a chance to meet with the PFAC members, and we're happy to share that PFAC unanimously endorses the OVOHT Aging in Place document. And we endorse it because it has concrete commitments for change that includes shared decision-making with parents, families, and caregivers, along with the various healthcare providers. It also identifies tangible opportunities for healthcare providers to work towards a truly integrated care approach to support individuals, their families, and caregivers. So looking at the first bullet, a rural lens or rural reality, we have an aging population and are in rural communities with geographic barriers to access services and supports. Presently, we are seeing a rise in the number of seniors in their 80s and 90s and expect those numbers to go up by 2030. Our sense is we need to begin taking next steps to move towards realizing the vision. Recognizing our reality, this report is inclusive of the accessibility issues and other current issues that can be supported with improved infrastructure and technological resources that will be further advanced by 2035. So why change? Wait a minute, I need to adjust my glasses. From a patient and client perspective, aging can be scary. Change also can be scary for everyone, including healthcare providers and leaders. We can see that this is another opportunity to develop supportive structures and to help healthcare work optimally while enhancing the successes of the OVOHT. And the last point with equity, through the equity lens that Jema described, PFACT is committed to help move the plan forward. The first strategic goal of establishing community health tables is one area that PFACT sees how they could be supportive of this by bringing together community groups and resources to develop an expanded community table. And when we were discussing things, several questions came up. So these are ones for you just to think about, and hopefully we'll have time to talk about them. How could we move forward with the first recommendation of a community table? And the next one, I'll let you know all three questions. Do you have any concerns? And how can we avoid duplication? Any feedback, or shall I go on for now and we might come back to them? Okay, I'll press on, but I think these are keeper questions, so we'll look forward to your responses. The second recommendation, moving into an integrated coordinated access point across the full range of care, is a game changer that will help us realize the vision. The question I had was, do we have an environmental scan? Jema, I'll look to you for that one. Has an environmental scan been done of services and programs?
I will say not comprehensive lately. And Sarah's nodding, so.
Okay, all right. Because I thought if not, and I just didn't know the answer to that, would you see this as an important step to help inform each other as well as the process moving forward? So that might be a strategy that and some action plan. The last strategic goal suggests that equity isn't achieved through access alone, and it must ensure equity is also reflected in health outcomes. The members of PFAC will work in tandem with the OVOHT to build the better communities that are envisioned. Community-driven co-design can be led by PFAC. Any thoughts before we move to the next slide? Nope. All right. The next one is really an opportunity to look at feedback that we've received from patients, their families, or caregivers. And I think it helps to ground our conversation. Caregivers not only have the primary responsibility for care of their family member, they also must coordinate and plan for all aspects of support that are required for the individual. All the while, they are responsible for their home, their yard maintenance, meal preparation, grocery shopping, banking, and other errands, as well as coordinating or providing transportation, as well as looking after their own healthcare needs and social needs. One caregiver suggested, moving forward, it will be really important that the integrated care model for those who have a progressive disease be responsive and supportive and not defined or limited by boundaries or turf wars. It will be about responding and supporting the patient or client's needs in a timely fashion with the supports and services that are needed. And another suggestion from another person was, it takes energy and time to coordinate everything with someone who requires a lot of care, and it's helpful to have a preset meeting time for a phone call instead of random call, which could occur in the middle of when they're providing care for their loved one. I then must, if there's a telephone call left, loop back to the voicemail. That causes more stress, waiting times, and multiple calls. I think you get into the you're it. You have to know it's all right to ask for help and to advocate. And I do believe that's a learned skill. Advocate for yourself and your family member. Here are a couple of examples of advocacy. I had to call the community paramedics regarding my husband who was getting sicker. I had spoken to others and did not receive any support. Then I finally decided to call the paramedics myself. I was very pleased when the paramedic response was, "Leave it to me. I will look after it. Feel free to call us back." The stress I felt feeling was lifted. The stressful feeling I had was lifted with that one sentence. I only had to make one call. Another person stated that when her mother had dementia, and when she was asked if she needed help, she'd say, "No, I have my daughter." It was only when her daughter talked to her mother's doctor and said she could no longer do it anymore, as her mother's needs were much greater than she could cope with, that they actually got help. So those are two really good examples of advocating for yourself or the person that's in your care. So in wrapping up, and Bonnie, I'll leave it up to you if you have something you want to add as well. By including the strategic goals, we have the beginning of a roadmap and a path to identify next steps. We need to lay out what is positive and possible to support this transformational 10-year vision that will be truly making a difference and for better outcomes for patients, caregivers, and their families, as well as the medical profession. So the challenge for each of us as individuals would be, what are your next steps? And for all the agencies and programs that are going to be a part of those community tables, what could their next steps be?